Good afternoon, everyone. I am on behalf of the National Foundation for Infectious Diseases. Thank you for joining us today to discuss the current state of adult vaccinations in this country. I'm Dr. Susan Ream. I'm the Medical Director for the National Foundation for Infectious Diseases, and I'm Vice Chair of Infectious Disease at the Cleveland Clinic. The title of today's session, Vaccines Across the Years, has a dual meaning. First, it's about what vaccines have accomplished and what they promise for the future. For example, vaccines have had enormous public health impact over the last 6 decades. They continue to be valuable today, and they promise to deliver even more health care benefits in the future. But across the years has another meaning. It also refers to the importance of vaccines to us as individuals. We needed them as infants, toddlers, and as adolescents, but we also need them as adults. In some areas related to vaccination, we do very well, and the pediatric vaccination program is a great example. We have wonderful vaccination rates in young children. As you know, since the 40s, our vaccine arsenal has grown tremendously. Because of that, we see today only a fraction of the vaccine-preventable diseases that we did in the past, and a fraction of the deaths and sufferings from these diseases. But there are lower vaccination rates in adults, and they show us that maybe we're starting to take vaccines and immunity for granted. What this means for the future is of great concern. This is one area where we cannot rest on our laurels. Our accomplishments will be undone if we don't maintain our immunity as adults and as a society. Death is the most dramatic outcome from skipping vaccines, but in addition to the tens of thousands of vaccine-preventable deaths in this country each year, millions more Americans get sick, miss work, and need medical care or are hospitalized. Some recover easily and some don't. Many will pass their infections on to family members, to friends, to coworkers, and countless others. And some of them will not recover easily. So skipping your vaccines is not only all about you. It's mostly also about those people around you. It's about the very successful public health program we have in this country, a program that has led to longer, healthier lives for all of us. This is a very serious issue and one that NFID believes warrants our attention. Yes, there are very serious health issues that we face every day, but there's a word that I want to stress here, and that is preventable. We are talking about preventable illness and preventable deaths. So we're particularly pleased today to have this blue ribbon panel of experts here to discuss the topic. They will introduce themselves before they speak. And I just have a few housekeeping notes. First of all, we're going to hold questions till the end, so we'll have a little panel discussion at the end. Well, if you're on the webcast, you can email your questions, and if you're on the teleconference, you can get instructions from the operator when the question session starts. The material in your press kits summarizes a lot of what you'll hear today and provides more information and more detail in some areas. You'll also find the material online at NFID's dedicated site, which is called adultvaccination.org. Now I'm going to turn the podium over to Dr. Melinda Wharton, who will share with you some new adult immunization data from the CDC. Dr. Wharton.
Thank you. I'm delighted to be here today. I've been in the immunization program for many years, and most of that time has been spent on issues related to childhood immunization, where as Susan said, we've done really well in terms of coverage, but there's so much we could do on the adult side. And I think the new data that was released today by CDC from the 2009 Health Interview Survey really show us what opportunities we have to improve prevention of disease among adults. Everybody knows, I think, or almost everybody knows, that children need to be vaccinated, but adults need vaccine too. And to the extent that adults don't appreciate the benefits they could achieve, or healthcare providers don't take advantage of clinical encounters to offer vaccines, we have missed opportunities for prevention. The slide that's up shows in a graphic way the adult coverage as reported by the National Health Interview Survey for a number of adult vaccines. And what you can see in a general way is that for most of them, coverage isn't as high as we would like it to be, but there are trends that are going up, and that's good. And I think that reflects an increased focus and attention that's been given to some of the adult vaccines in recent years, as well as new recommendations that just take a little while to be implemented. So I'll go through some of these briefly. Pneumococcal polysaccharide vaccine has been recommended for adults over 65 and for people in high-risk groups now for many years. And we've had slow increases in coverage over the years, and it's stable since 2008 at about 65%. But one thing that summary graphic doesn't show us are the differences in coverage between people over 65 who are white and people over 65 who are non-Hispanic black, where coverage is about 20 points lower, and it's also lower among Hispanic Americans. So this is an area where we do have disparities in coverage, and those disparities need to be addressed in order that really all Americans can receive the benefits of prevention of disease. With some of the newer vaccines, we do see increases in coverage, and that's terrific compared to 2008. Human papillomavirus vaccine was recommended by the Advisory Committee on Immunization Practices in 2007, and for women up through age 26 years of age. So in terms of the adult data, we're looking at women 19 to 26 years of age, and of those, in 2009, about 17% had received at least one dose of HPV vaccine. Now, this is a 3-dose series, and it's important that women complete this series, but at least we've got women who have initiated the series, and this is up 6.6% compared with 2008. So that's moving in the right direction. Another of the newer vaccines is herpes zoster, the shingles vaccine, which prevents shingles, and it's recommended for routine use in adults 60 years of age and older. This is a vaccine that can prevent a condition that can be really debilitating and painful for older people in particular. And coverage with zoster vaccine is up a little bit from 2008. It's only 10%, but it is up 3% over 2008. So again, it's moving in the right direction, but it's still much lower than it needs to be. For hepatitis B vaccine, we have coverage among people in high-risk groups for whom we recommend vaccination that's up 6% over last year to 41.8%. And this includes a particularly striking increase among non-Hispanic blacks who are in high-risk groups for hepatitis B, where coverage is up to 43.6%, almost the same as it is for non-Hispanic whites, and this is up 13.6%. So this is really, it's great seeing those disparities in coverage disappear. As we get new vaccine recommendations made by ACIP, it does take a while for them to be fully incorporated into clinical practice, and there's a lot of reasons for that. Doctors have to go through vaccine procurement, the staff has to know how to store and handle the vaccine, and a variety of reimbursement issues need to be addressed, as well as it just needs to be incorporated into the clinical routine in the office. But this begins to happen once these recommendations are made, and so I'm hopeful that we'll continue to see increases in coverage of these new vaccines. But we clearly have lots of room for improvement, and I think this is a challenge that we all need to accept about what is it going to take to do as well with adult vaccination as we're doing with children. And of course, fundamentally, this is about preventing disease, and we do get reminders of this from time to time. Right now, there's a reminder that's going on in the state of California, where there's a large pertussis outbreak going on. There also are pertussis outbreaks in other parts of the country, but the one in the state of California has been quite large. There have been a number of infant deaths, and has generated a fair amount of publicity, and there's been an ongoing investigation that CDC's been involved in there. It's not that the major driver of that outbreak is susceptibility among adults, because I don't think there's good evidence to support that at this point. But certainly, adults who are susceptible pertussis can and do transmit infection once they acquire it to young children in their household, especially, or children who are under their care. And so for adults who have contact with young children, there's a great opportunity for prevention in terms of protecting those young infants from pertussis by getting vaccinated. And we recommend the vaccine to replace the tetanus diphtheria vaccine for adults up through age 64, as well as for adults 65 and older who have contact with infants. With pertussis vaccine, we can't vaccinate the youngest children by vaccinating them directly. The pertussis vaccine takes several doses to confer protection, and we give it in infants at 2, 4, and 6 months of age. And after the second or third dose, there probably is some protection, but there probably isn't after the first dose. So during those first few months of life, the only way we can protect children is by not exposing them to pertussis in the first place, which means the people around them need to not acquire the infection. And the way we can do that is by vaccinating the adults who surround that young child in a strategy known as cocooning. We do have 2 licensed vaccines for vaccination of adults, and with better use of those vaccines, we should be able to do a better job to protect our youngest and most vulnerable infants. Finally, I think we can, one thing that will help us do better with adult immunization should be, as the provisions of the Affordable Care Act are implemented, more people should have better coverage for preventive services, including vaccines. This should reduce fiscal barriers and improve the certainty on the part of medical providers that these are services that will be covered by their patients' insurance. And really, I can't overstate the importance of healthcare providers in getting people vaccinated. That's who people want to get advice from. They want to hear from their doctor about what's in their best interest for their health and what do they need to do to take care of themselves. And so medical providers play a really key role in making these recommendations to their patients, staying informed about new recommendations as they're developed, and providing opportunities for their patients to get vaccinated in the office setting, or making recommendations about where they can get vaccinated if they choose not to offer vaccines in their office. These are areas where we can do better. We can get those graphs, get those lines moving upward, and I think with new vaccines and new recommendations, we've got a great opportunity for improvement. Thank you.
Thanks very much, Melinda. The results that you presented are very encouraging to those of us working in this area. NFID and like many other organizations, we're out there promoting vaccine according to the CDC schedule. Based on what you've said, it's working, but perhaps a little bit more slowly than we'd like. This year, in order to gain additional insight into how we can optimize adult immunization, NFID conducted 2 national surveys, one of consumers and one of physicians. What we found is an interesting group of findings. First of all, doctors are committed to vaccines. Secondly, patients are very receptive to getting vaccines. But there seems to be a significant communication breakdown between providers and consumers. Let me talk a little bit more about that. First, about physicians. One of the things that we first looked at was vaccination rates among physicians, because those vaccination rates are a pretty good measure of how committed physicians are themselves to the vaccination program. According to our survey, 92% of physicians have been vaccinated against influenza, 85% have been vaccinated against hepatitis B, and the majority have received either tetanus diphtheria or the tetanus diphtheria acellular pertussis, the Tdap vaccine. These data very much parallel the data that you've been shown, but because physicians as one type of healthcare worker have been separated out, I think if you see the overall rates for healthcare workers, they're a little bit lower than they are for the physician-specific rates. One other way that we can measure the commitment of physicians to vaccination is what they say about how they communicate with their patients about vaccines. In our survey, physicians said that they discuss all vaccines with 87% of physicians say they discuss the vaccines with every patient who comes in their office. An additional 12% say they discuss vaccines with every patient who has a risk factor or an underlying health condition. So if you add that all together, that leaves only 1% of physicians who say they generally do not discuss vaccine. But here's the big disconnect. When we talk to consumers in our surveys, nearly half, 47%, said they don't recall ever discussing vaccines other than influenza with their doctor or other health care provider. In fact, 1 in 5, or 21%, can't recall ever discussing any vaccine, including influenza. Here's another big disconnect. Doctors say that they or their staff initiate vaccine conversations 99% of the time. Flip that over to patients. 45% of patients say they're the ones who bring up vaccines in a vaccine conversation. Another big disconnect. Clearly, as healthcare providers, we are encouraging patients to take charge of their health care and to ask about vaccines and other preventive measures. But we really need to do a better job as healthcare providers at conveying the importance of immunization to our patients, particularly to our adult patients. Melinda mentioned the strength in asking patients, providers asking patients about vaccinations and encouraging vaccinations. Nearly 9 in 10 of the adults we surveyed say a strong recommendation from a physician would be a very likely motivator for them to get vaccinated. So overall, I think these findings are in a way encouraging. Although we have this disconnect, we have a very solvable problem, and that is communication. That is certainly a fixable situation. Patients need to hear the recommendations from their provider, and it needs to be clear. Practices need to institute formal procedures to make sure that vaccines are discussed and the value of vaccination is reinforced at every visit. That is particularly important for adults, where every visit needs to be an immunization visit. We don't get adults in for routine care as often as we like, and we don't necessarily think about vaccination in the context of either routine or emergent care. If we're able to do this, that would go a very long way in improving adult vaccination rates. Our subsequent speakers will share more specific details of these findings throughout their presentation, but I want to share just a few more highlights of our surveys, which were conducted over the past few weeks. The physician survey was one of 300 primary care physicians, and it was conducted online. The consumer survey of just over 1,000 adults 18 years of age and older was conducted by telephone. We also conducted a very similar consumer survey last year, and I want to compare some of the results with this year's results. Overall, we're seeing an upward trend in the number of adults who say they are extremely or very familiar with vaccine-preventable diseases. That, again, is great news, but we have a long way to go. For influenza, we're up 8% from last year to a total of 78% this year. Shingles went from 6% up to 49%, really astonishing growth. And for pertussis, we're up from 17% to 49%. Unfortunately, this may be due in part to the outbreaks we're experiencing. And I'd like to go back to shingles for correction. I apologize. Last year we were at 43%. This year we're at 49%, so it was a 6% increase. So pertussis is up 17%. Pat Joseph is going to talk with us about the pertussis outbreaks, and I'm sure that that has contributed to a consumer awareness about it. For HPV, we're up 7%, but still the awareness is only at 37%. So only a third of consumers were aware about HPV vaccine. Pneumococcal vaccine is the only one that we didn't see, where we didn't see an increase in consumer awareness. And I guess that's not surprising. There hasn't been a specific consumer media or advertising campaign related to pneumococcal disease. So we can probably all take all this to mean that all the education and outreach from public health, medical, and immunization communities is having an impact on consumer awareness of disease and also of prevention. Still, and this is pretty astonishing, only half of American adults are aware that there's a formal schedule of adult immunizations that's applicable to them. 1 in 5 believe that vaccinations are optional for healthy adults. And another 19% believe that vaccines are not recommended for adults except for influenza and travel vaccines. We have a long way to go. Let's move on to what motivates adults to get vaccinated. The strongest motivator, when we're repeating this because it's important, is a recommendation from a doctor. 88% of people who were surveyed endorsed that statement. 83% say a better idea about how effective the vaccines are would make a difference in whether they sought vaccination. 79% say they'd be motivated by more information about how vaccine preventable infections and cancers are linked, and we're going to talk a little bit about that later. And then there's a cost-related motivator. 75% people say if health insurance paid for it, they'd be more motivated to get vaccinated. Now, as you probably know, Medicare pays for influenza, pneumococcal, and hepatitis B vaccines in full, and there are many other health insurance plans who offer various levels of coverage for vaccines as well. So I think the perception and reality may not be quite the same there. We obviously can improve in that area as well. So these are just a few of the findings from our several surveys. You'll hear more from our speakers, and there's also a backgrounder piece that's available in your packets or online for those of us who are joining us by webinar. And now I'd like to turn the podium over to our next speaker, Pat Joseph.
Well, thank you, Susan. I'm Dr. Patrick Joseph. I'm an infectious disease physician in California. Currently, I am the Vice President of the National Foundation for Infectious Diseases. My comments today are going to be to discuss an old disease, that's pertussis or whooping cough, and introduce a concept that maybe some of us who had childhood vaccines in the 50s and 60s and 70s are now becoming susceptible, meaning the childhood shots or baby shots are wearing off. Now, first about pertussis. Pertussis or whooping cough is a respiratory disease. It starts off like a typical cold, a runny nose, but it doesn't go away. It lasts a couple of weeks and then goes into a phase of serious continuing coughs, spells that last all day long, followed by a childhood whoop or a noise when they're breathing in. In the 1950s, this was a devastating disease. We had over 250,000 people every year in the United States get whooping cough, with many, many deaths. And this is a vaccine success story. Throughout the 1950s, baby shots started to include immunizations for whooping cough. And in the 1950s and 1960s, there was a 90% reduction of whooping cough. A great story for vaccine, a great story for baby shots and childhood immunizations. But now, and especially in California, it's back, and it's back with vengeance. This year alone, in the year 2010, there are over 6,500 cases of whooping cough in California. Many of them in children, many of them in adults. And the reason, or at least one of the reasons, is that adults now are susceptible, suggesting that the baby shots are wearing off. You know, it's been 40, 50, 60 years for some adults in California across the United States who had childhood baby shots, and now they're susceptible. Now, when an adult gets whooping cough or pertussis, it's a very annoying disease. It's 6 weeks of coughing, but usually adults do pretty well. They may have some partial immunity, or maybe their immune system is more mature than babies. They get it, it's annoying, they miss a lot of work, but it doesn't have a lot of mortality. But here is the main point. This is the take-home point for today. When adults get whooping cough, it is incredibly contagious, and they're spreading it to children, to babies. Infants are not born with natural immunity to whooping cough. When infants are born, they don't have mother's protection. And even with baby shots, they're not protected until about 6 months of age. So if a baby is exposed to an adult who's coughing from whooping cough, the baby gets very, very seriously ill. In California alone, we've had hundreds of infants in the intensive care unit, and as of this week, 10 infants have died in California from a completely preventable disease. So in reality, this is an epidemic of adults, but a tragedy of infants. Now, the good news is that there is an adult booster that is available. This became available 5 years ago. It's a tremendously valuable vaccine, very, very successful. And currently, the recommendation is all adults get a booster shot. Starting at age 7 in California, age 11 around the country, all adults should get a booster shot. If adults are protected, then they won't transmit this disease to babies. So in conclusion, the most important thing to recognize from this is California's pertussis outbreak is not limited to California. It's across the country, it's across the world. There are thousands of cases in other countries, and the best way to prevent this and curtail the epidemic is one shot, one time, all adults. Thank you very much. Next, Dr. Katherine Georges will be discussing other vaccine-preventable diseases.
Thank you. Good afternoon. As a nurse, I'm gratified to see so much attention paid to such an important topic, and I'm honored to be here speaking on behalf of AARP as a board member. This is the season when I flinch every time someone around me coughs or sneezes. In the fall, every sniffle might mean flu, and that's something I take seriously. Many people dismiss the flu as a minor annual nuisance. You know, I'll stay in bed a couple of days with aches and fever, maybe a bit of coughing and snorting. I guess that the people who think this way may never have had the flu. The reality, however, is much worse. Complications from influenza contribute to some 200,000 hospitalizations each year in the United States. And among our most vulnerable populations, seniors and children, the flu can be deadly, claiming in some years 50,000 lives. According to the Mayo Clinic, 95% of these deaths occur in adults aged 60 and older. Although last year, the H1N1 affected younger people and children more than any other group. So my plea today is certainly to those older Americans to get their flu shots. But I'm also urging every adult to get vaccinated. The flu vaccine is now universal recommendations, which means it's recommended for all Americans. There's plenty of vaccine available, and it comes in 3 forms: the shot, a nasal spray, and a new shot for those age 65 plus. Widespread, as has been noted from our other speakers, benefits everyone. You're at less personal risk, and you're less likely to pass along an infection, miss out on work or a paycheck, and better able to meet your daily obligations. If you're a caregiver, as so many of us in the 50-plus age range, think about the impact of getting the flu. It would keep you from taking care of your kids, your grandkids, and or your parents or a significant other. If you continue to be around them, it could put them at risk of getting this terrible infection. The Centers for Disease Control and Prevention, CDC, also recommends pneumococcal vaccination for people 65 and older, and for younger people with certain risk factors like smokers, heart patients, cancer survivors, and people with asthma. Pneumococcal disease is the leading cause of community-acquired pneumonia in the United States, and the pneumococcal bacteria also causes meningitis and blood infections. Everyone in the recommended categories need to be vaccinated at the youngest recommended age when the immune system is at its best. Although vaccination rates among people 65 and older are promising, about 66% for flu and 60% for pneumococcal disease, they are still well below the healthy people 2010 goal of 90%. A survey by NFID found that only about half of adults aged 60 and over have discussed pneumococcal vaccination with their physicians. And it's disturbing, and you heard the message from Dr. Wharton, that flu and pneumococcal vaccination rates for African American and Latinos are significantly lower than that for their white counterparts. Since anyone 65 or older with Medicare can receive the vaccinations with no insurance or copay by seeing a recognized provider, then we should be raising those numbers. Sadly, the flu vaccination rate for the 50 to 64 is only about 34%. 30% of all people who refuse the flu vaccination and 42% who turned down the pneumococcal vaccine said it was because they were concerned about they were not concerned about getting the disease. You know, they're taking a risk. Getting vaccinated means taking a responsible step for our own health as well as the health of people around us. This flu vaccine, look out for yourself and for the people around you, whether you're a commuter in tight quarters or caring for loved ones at home. It's time to pay special attention also to eating well, staying hydrated with lots of water, and washing your hands frequently with warm, soapy water to reduce germs. If you think you've got the flu, stay home. Drink plenty of fluids, get rest, and please cough or sneeze into your elbow. Don't share your virus with others. Even better, avoid the misery of the flu and of pneumococcal disease by getting vaccinated. We will all thank you. Thank you.
Thank you, Katherine. I just want to introduce myself. I'm Dr. Jeffery Cohen. I work at the National Institute of Allergies and Infectious Diseases at the National Institutes of Health. And I'm here today to talk about the importance of getting the shingles vaccine for individuals who are age 60 and above. I want to start on a very personal note and talk about a person I know very well who had shingles, and that's my father. When he developed shingles, it profoundly changed his life. Before he developed shingles, he was the manager of a branch of a local bank. He was very active. He worked long hours. He enjoyed talking to his customers, including during his lunch break, and he had a very active social life. After he developed shingles, he developed a long-lasting pain that sometimes occurs in individuals even after the rash is resolved. For months afterwards, he was very depressed, he was unable to sleep at night, and he was in nearly constant pain, despite seeing a number of physicians and trying a number of different medications. He actually retired from his job and never returned to work. When he finally recovered over a year later, he confided to me that he'd actually thought about suicide. He told me he would never wish shingles even on his worst enemy. And he said if ever there was something that could prevent him from getting another case of shingles or preventing anyone from getting a case of shingles, he'd be the first in line to sign up for this. So I'm here to say that we do have something to help prevent shingles, and that's the shingles vaccine. Shingles is caused by the same virus that causes chickenpox. And when we get chickenpox, that virus stays in our nervous system for the rest of our life. It can then reactivate later on in life and cause the rash associated with shingles as well as the pain. As you know, most of adults in the United States have gotten chickenpox, so most adults are at risk for getting shingles. And my father's not unique. It's estimated that 30% of people will develop shingles sometime in their lives. And for those who are who live up to the age of 85, 50% of people will develop shingles. So those over the age of 60 are not only at the higher risk of getting shingles, but also at higher risk of getting the pain associated with shingles, as well as this post-herpetic neuralgia, that is the pain that persists long after the rash is resolved. Patients with post-herpetic neuralgia have severe pain that can, as I mentioned, can interfere with sleep. It can make them very withdrawn, and it can make them have constant pain that can be very difficult to relieve. The treatment of shingles, it can be difficult, and unfortunately the same patients that are at the highest risk of developing shingles are also at the highest risk of having side effects from some of the medications used to treat shingles. In addition to causing pain, shingles can have other side effects. Shingles can infect the eye, and when it does that, if it's not treated, a patient can have loss of vision in their eye. Shingles can also affect the blood vessels in the brain, and some individuals can have strokes related to getting shingles. As I mentioned, there is a shingles vaccine, and it was studied in over 38,000 people. This vaccine cut the rate of shingles by 1/2 and cut the rate of post-herpetic neuralgia by 2/3. The shingles vaccine also reduced the duration of pain and the severity of pain in people who did have breakthrough, who did get shingles after getting the vaccine. Importantly, there were no serious side effects from the vaccine in this large study. So the vaccine is recommended for persons aged 60 and above who are not immunocompromised. Now, we do have an effective vaccine for shingles, but only 16% of adults know that this vaccine is recommended for persons aged 60 and above. And as you've heard, only about 10% of people who are eligible for the shingles vaccine have actually received it. So I've seen many patients over the years who've had shingles, including my father, some of whom were really devastated by this disease. And it's important to get this message out today that we do have a safe and effective shingles vaccine. So now I'd like to introduce Dr. Maura Gillison, who will talk about vaccines and cancer prevention.
Thank you very much for the opportunity to represent the oncology community here today. I'm Maura Gillison, and I'm professor and Jeg Coughlin Chair of Cancer Research at The Ohio State University. And I'd like to say that the cancer community is extraordinarily excited about a major advance in cancer prevention, and that is that we now have 2 extraordinarily effective vaccines to prevent cancer: the human papillomavirus vaccine and the hepatitis B vaccine. Approximately 18% of all cancers diagnosed worldwide each year are caused by infections, and hepatitis B and human papillomavirus are the leading culprits with regard to viruses. Unfortunately, hepatitis B is a leading cause of liver cancer worldwide. There are about 360,000 cancer cases, liver cancer cases each year caused by hepatitis B. And as an oncologist, I can tell you that unfortunately the disease is almost universally fatal. There are not very many effective treatments for this type of cancer, and unfortunately most people will die from it within 5 years of diagnosis. Hepatitis B is an example of an infection that contributes to cancer development by what we call an indirect mechanism. Some people who are hepatitis infected, and there are 30% of the world's population that have been infected at one time, 6% become chronic carriers of the virus. Chronic infection causes damage to the liver, inflammation, and fibrosis of the liver in some individuals. And individuals who have chronic hepatitis B infection are 15 times more likely to develop liver cancer. And those who have chronic infection and cirrhosis have about an 8% risk per year of developing liver cancer. Fortunately, there's very, very good news in that we now have, as of 1982, an effective vaccine to prevent hepatitis B infection. And prevention of infection means prevention of cancer for most individuals. In some regions of the world, hepatitis B is very common, and infection is frequently transferred from a mother to an infant. And in Taiwan, 2 years after the vaccine became available, the Taiwanese government made a decision to try to attempt to get universal vaccination of infants at birth. As a consequence of that, after 1984, the chronic carrier rate of hepatitis B among children dropped remarkably from about 10% to less than 1%. Also, fortunately, the rates of hepatoma, or liver cancer among children, dropped by 70% among vaccinated people. Extraordinary example of how vaccines can reduce cancer, both worldwide and in the United States. Fortunately, the U.S. in 1991 made the decision to recommend universal vaccination of infants with hepatitis B vaccine. But unfortunately, those in the adult category, those still 20 and older, unfortunately are at risk. And there are about 720,000 to 1.4 million people still chronically infected with hepatitis B in the U.S. who are at risk for transmitting the infection to others and who are at risk themselves for liver cancer. Now let's switch to human papillomavirus infection. That's the area of my interest academically, and I can't tell you how excited I am that we now have a vaccine that's extraordinarily effective for prevention of human papillomavirus infection. Human papillomavirus is an extraordinarily common infection. The CDC estimates that 80% of women will at some time be infected. HPV is known to be the necessary cause for cervical cancer, which is the 5th most common cancer worldwide. In developing countries, it's the leading cause of cancer death among women. HPV is also an important cause of non-cervical cancers, vulvar cancers, vaginal cancers, anal cancers, and oropharyngeal cancers among women, and penile cancers, anal cancers, and oropharyngeal cancers among men have been linked to human papillomavirus infection. Fortunately now we have an effective HPV vaccine. There are 2 that are FDA approved in the United States, and they provide protection against the leading causes of HPV-caused cancers, HPV 16 and 18 infection, which cause about 70% of cervical cancers worldwide, and greater than 90% of non-cervical cancers caused by HPV are covered by these vaccines. There are regions in the world which, after the HPV vaccine became available, who made major public health decisions to vaccinate through government-sponsored programs in schools young women who are at risk between the age of 9 and 17. For instance, in England and Australia, already 80% or greater of young women in this age range, and in Australia also young men, have been vaccinated already. When you have coverage as high as 80%, what you can expect and anticipate in the future what is called herd immunity, whereby even individuals who have not been vaccinated will benefit. Unfortunately, in the United States, the uptake of the HPV vaccine has been considerably less. The CDC recommends vaccination for young girls and women from age 9 to 26. And unfortunately, in the 9 to 17 category, only 40% have received one vaccine, and unfortunately, only about 17% have received all 3 vaccines. So we may be, as an oncologist, losing an opportunity to reduce cancer rates. I'm a head and neck medical oncologist, and I treat a newly recognized disease entity, which is HPV-associated head and neck cancer. And the treatment of that malignancy is incredibly difficult. Patients are left sometimes with speech and swallowing disorders that are lifelong, that affect their social interactions. And in my practice, my patients tell me, I don't understand this contention over the HPV vaccine. My gosh, if people knew what I personally am going through, and if I had had the opportunity instead to have gotten 3 shots when I was a teenager, believe me, I'd exchange that in a minute. There are 20,000 families affected each year by a cancer caused by HPV in the United States. Effective use of the vaccine could prevent those 20,000 individuals and their families from the incredible experience of having an HPV-caused cancer. The last thing that I wanted to say is we now have 2 incredibly effective anti-cancer vaccines, and there is hope for the future that if I have the opportunity to do this again, that we may be talking about the 3rd and the 4th and the 5th anti-cancer vaccines in the future, because research is showing that there are many other viruses that are also linked to the development of cancer: Epstein-Barr virus and nasopharyngeal carcinoma and lymphoma, HIV and lymphoma and other infection-associated cancers. There's HTLV1, which is a rare cause of leukemia. And the list goes on with newly described viruses, for instance, most recently Merkel cell virus. So as of right now, we have the potential with the vaccines that we have of preventing as many as 1 million cancer cases a year. So I strongly urge people to consider what a remarkable public health advance this is. Thank you.
Thank you very much, Dr. Gillison. I want to thank all of our panel members today for your personal commitment to furthering the cause of adult immunization and for talking about your personal experiences with a very broad spectrum of adult vaccination. I'd like to ask my professional colleagues going forward a couple of things. First of all, to set a goal of getting all of your adult patients fully immunized. And secondly, to establish procedures within your practice and talk to your staff about why vaccines are so important and how we can get patients protected. I know very well how busy primary care physicians are, and there's tons of things to be covered in every visit. In our survey, 57% of doctors said that they really didn't have adequate time to discuss vaccine and that was an obstacle in vaccine education. But the immunization discussion doesn't need to be long. It needs to be concise and clear. So when I talk with my patients, I don't say, I think you should consider the vaccine and so on down the line, but simply, I recommend that you receive this vaccine. And I think that our data show and in practice shows that patients are actually quite receptive to that and very much look to their physicians and other providers for that recommendation. As far as the public is concerned, please don't wait for your healthcare provider to bring up vaccines. Ask which ones you need. You can go to adultvaccination.com or cdc.gov for additional information. They're wonderful websites with a lot on them. So we've reached the end of our formal presentation. We're going to open up for questions. I'd like to thank you all for listening with us today. We are going to have a multimedia task of answering questions. First of all, live in the room, we're going to have roving microphones, so if you'd like to ask a question, raise your hand, someone will come over. For all of you who are participating in the question session, please identify yourself, list your affiliation, and that'll help us along as well. For those of you who are participating by webcast, you can email us questions and they'll be asked in the room. And if you're on the teleconference, the operator will be coming on the line shortly with instructions about how you can ask questions. And finally, for those of you who would like to schedule individual interviews with any of the panel members, please let a member of our staff know, and we'll be happy to arrange that for you. So I'm ready for first questions. I don't know if we might be taking one from the web or the phone or in the room, but we're open for anything. All right. We're waiting for the phone lines to open up. And while we have a moment, I'd like to thank all of you who participated today. Again, both live in the room, live by via web, or by whatever means. We appreciate your interest and your willingness to help us get the word out about adult immunizations. Pat, while we're waiting, I wondered if you could give us a little sense of how things are in your area with the pertussis outbreak and all of the news about changes in immunization recommendations. How do you see your colleagues implementing these things? What's the atmosphere there?
Well, thank you. Again, this is Dr. Pat Joseph. The pertussis outbreak in California is in the news every day, and essentially everyone has been touched by it. With the public media making statements that every adult has an obligation to prevent the illness in children, then there's a lot of interest. Comments have been made that for those adults who have children, grandchildren, nieces or nephews, or know anyone who has any children, grandchildren, nieces or nephews, there is an obligation to get pertussis vaccine. And with the excellent efforts of the California Department of Public Health, I would say that the response has been very, very good.
Thank you very much. Melinda, I wondered if you could comment. We every decade go through a process of setting immunization and other wellness goals through Healthy People. We just passed Healthy People 2010. We're setting up goals for 2020. How did some of the measured adult immunization data measure up against the 2010 goals, and do you have any information about where we'll be in 2020?
Well, the Healthy People 2020 goals are still under development, so but I will expect that there will be goals for additional vaccines other than the ones that we now have. The area where I think we've got the biggest room for improvement with the vaccines we've been using for a long time is really with influenza and pneumococcal disease, where there's substantial room to do better. And again, the ongoing existence of disparities among African Americans and among Latinos is really troubling. These are vaccines that have been available for a very long time, and it seems like we ought to be able to do a better job of really providing those benefits to all the people in our country.
Traditionally, there's been a big gap between the 65 and older groups and those who are younger than that in terms of influenza immunization in particular. Can you speak to where we might be going with that?
Well, as new recommendations are made, it takes a while for them to be fully implemented, and our recommendation for universal influenza vaccine for everybody 6 months of age and older is a new one. But even for the people under age 65 who have underlying high-risk conditions, or the people in the 50 to 64-year-old 12-year-old age group for whom we had an age-based recommendation for many years, we haven't gotten the level of influenza vaccination that we really need. So there's lots of room to do better. I will say that we all learned a lot about influenza in the last year, so I'm hopeful that we can continue to do better, but there's a lot of room for improvement.
Thank you very much. Katherine, would you like to speak to the 50-plus generation in terms of any particular strategies that you think they might use to inform themselves and to get their vaccinations up to date?
Well, I believe that the 50-plus group who thought they're fairly healthy, the baby boomers, they're physically fit, they're involved in exercising, they're eating well, and they feel that they're not going to get sick. And so that has been what has happened. I think we just have to continue to launch our campaign and continue to get across how critical it is, because they are also the ones who have parents who they will be caring for. They'll be having grandchildren. They have children, and they need to be concerned about if they get the flu infecting the people around them.
It's striking to me because as I speak with people and from what I've read, that taking care of others, and in the case of pertussis, protecting the unprotected babies and so on, that taking care of others really speaks to the sandwich generation, a very strong motivator.
Very much so.
Well, once again, I'd like to thank everyone for participating. It's been a tremendously informative time, and I wanted to remind you that if you wish to speak to individual panel members, please contact a member of the staff. We'll be happy to arrange that. Thank you very much.
Thank you.